Our first speaker this afternoon is Peter Kranz, who's the Chief of Neuroradiology at Duke University Medical Center. He knows a lot about spinal fluid leaks, and I think that's pretty much like me. That's the only thing you treat there, right? Yeah. Or do you do anything else in neuroradiology? No. That's it. Yeah, fantastic. Here he is.
Thank you very much. It's a pleasure to be here again and an honor to be speaking. I'm going to be another speaker talking about imaging tips and tricks. And it occurred to me, when Marcel was talking about the fact that there were multiple speakers talking about this and we all sort of had our own take on it. I think, in a global sense, we're doing all of this wrong. Because it's really much too difficult, too complicated. And 20 years from now, if we're doing everything the same way that we're doing it now, I think we haven't done our job. But on the other hand, I think it's really great that different people at different centers are doing this in different ways. Because ultimately, that's where sort of the innovation comes from, that's where the new discovery comes from. And I think if everybody's doing it the same way, then we're not moving things forward and we're not getting to that place where it becomes much easier. So just some disclosures. I am on the medical advisory board for the Spinal CSF Leak Foundation. I don't get paid as much for that as Wouter does. I may mention the use of fibrin glue, which is technically an off-label use, and the use of intrathecal gadolinium is an off-label use as well. So I think, my take-home point from this talk is that some imaging is not the same thing as good imaging. And I think that you can do imaging and only partially address the question that you're looking to address. Attention to technique is really critical, and I'm going to talk about some of the things that I personally have found important or helpful in doing some of this imaging, and also to emphasize that this is a moving target, so things change over the course of years, months, sometimes even weeks, and it's important to keep up with the literature. It's important to keep up with national practice, and I think meetings like this are perfect for that because it gives people new ideas and helps them stay abreast of what's going on. So just by way of overview, you've heard this before, but basically there are several different mechanisms by which one can get a spinal CSF leak. And broadly speaking, they break down into two categories. The first is etiologies that cause epidural pooling of CSF or epidural leaks. And the other very important group are the CSF to venous fistulas. And each of these two different groups have their own unique challenges when it comes to imaging. So how do I think about the approach to spine imaging in people with SIH? Well, I think, there's all these different techniques. There's digital subtraction this and dynamic that, and, how do you sort of, on a basic level, how do you make sense of it? So I think you have to think about an initial imaging study. What are you going to do first? And that initial imaging study has to be sensitive for detecting epidural fluid, so that first group of leaks by which you can see pooling of epidural fluid. And then you've got problem-solving techniques. Certain types of epidural leaks will have their own problems. Certain types of CSF CSF to venous fistulas will have their own problems. And you need a study that can help focus in on helping you out answering that particular question. So the first thing I'm going to talk about is problem solving with epidural leaks. You'll notice that I skipped that initial study, the debate between MR and CT imaging in the initial study. I think different places do that differently. At Duke, we start with the CT myelogram. At Cedars, they start with an MR. I think there's valid reasons to do both. We each have our own reasons for doing that. I think if you're starting with either one of those techniques, you're in a good spot. So when it comes to epidural leaks, the problem is that these are easy to see but hard to localize. And this is, I think, a theme you may have picked up from previous speakers. And by and large, what you need is something with high temporal resolution. So you need a fast study. And there are two kinds of studies that help you with the problem solving here. There are fluoroscopy-based techniques, which are called dynamic myelogram or digital subtraction myelogram, which are both basically the same thing. It's just one uses digital subtraction, the other doesn't. And then there's this technique that was developed at the Mayo Clinic called ultrafast CT. I think they may still call it dynamic myelogram, but I'm going to call it ultrafast CT, where basically you're scanning the patient in the CT scanner as you're injecting contrast. And these are the ones we use to help localize epidural leaks. So this is what they look like. This is an example of a dynamic myelogram. Just basically, it's a patient where you're putting them on a tilting fluoroscopy table, and you're tilting them head down and watching the column of contrast spread up the spine. And you can see a split in that column of contrast at the source of the CSF leak. You can do this with digital subtraction. It requires anesthesia with a breath hold or a very, very compliant patient. It produces very nice images. In some cases, it can be useful. In some cases, you may not need that. And then on the other side here, we have an example of ultrafast CT, where you can see this is cross-sectional imaging. This is a sagittal reformat. And you're basically looking for the same thing, the spot at which the contrast column splits into two different channels. So this is what you're looking for in each of these different cases. And this is where it helps you localize the leak. So here's an example of a dynamic myelogram. This is going to be a patient who has a leak coming from a diverticulum lateral along the spine. So this is just a static fluoroscopic image, and I'm going to be showing you pictures as the patient is progressively tilted further and further down. They're laying on their side. The contrast column is moving up the spine, and you see this diverticulum, which is starting to fill with contrast. And as you tip the patient further and further, you can see that there's actually contrast streaming out in the epidural space. Now, you know 100% sure that that is the site of where the leak is coming from, and it's that increased temporal resolution that you can get under fluoroscopy that will help you with that. So this is a great technique that you can use to localize. Here's another case of a dynamic myelogram. This was a 14-year-old girl with Marfan syndrome. On her CT myelogram, you can see she's just got this diffuse CSF leak. It looks everywhere. How do you know where this is coming from? This was an axial image from her CT myelogram, and you could see this kind of big diverticulum that was corresponding to this thing here, coming right out underneath the axilla of this nerve root sleeve, kind of a broad base against the lateral thecal sac. We thought that this is probably what was causing her leak, but wanted to be able to prove it. So these I'm going to show you are sequential images from a dynamic myelogram, and you're going to see contrast streaming up the side there, starting to fill that diverticulum, and then just streaming out above and below. So here you can see this is that big diverticulum that you can see pairs with the CT image, and it's just streaming out from above or below. Again, this helps you confirm exactly where this leak is coming from. This is the intraoperative video, and you can see this sort of very thin-walled diverticulum that it's really just the arachnoid pooching out, and as soon as it's encountered, it sort of ruptures and deflates. Here's another example of a dynamic myelogram. This is a patient with one of these characteristic little spurs of bone that looks like it's penetrating into the thecal sac. We wanted to be sure that this was the level that was causing the leak. So all you have to do is put the patient prone and start running contrast up their spine. You can see this column of contrast coming up. This is a zoomed-in image, and you start to see a little bit of a leak coming out at this particular level. On the next image, it's spread a little bit further, and again, it helps you confirm exactly where the leak is coming from. And this is something that's very easy to do. Most people will have access to tilting table and fluoroscopy. Sometimes you run into a problem with dynamic fluoroscopy and digital subtraction myelography, and that's patient's shoulders. Okay, so here's a patient who's got this very large CSF leak on their MR scan, which you can see here. This is what a lateral radiograph of this patient looked like. Okay, so very hard to see where this leak is originating from. Now, I'll tell you it's coming from in here, but exactly where, hard to see. Now, we happen to get this patient into what we call the swimmer's position, which is one arm up and one arm down, and the leak becomes a little bit more apparent. On the zoomed-in image, you can see the leak starting there. But leaks in this area, from T4 up to the lower cervical spine, very difficult to visualize because of the shoulders. So how do you avoid that shoulder problem? Well, in general, this is how I think about these leaks. If you've got a ventral leak above about the T3, T4 level, below it, I tend to use a dynamic myelogram or a DSM. Above it, I really like that Mayo ultrafast CT technique because you don't have to worry so much about penetrating through the patient's shoulders laterally. Lateral leaks, on the other hand, you don't have the shoulder problem, right? You're just looking through a shorter distance in the AP direction, and so dynamic myelogram or DSM is really sufficient in all of those cases there. So this is sort of how I think about that. So to avoid the shoulder problem in those high leaks, you want to use an ultrafast CT myelo. And here's an example of that. This has been shown before, so I won't belabor it. But basically, this patient is up on a big wedge in the CT scanner. You inject contrast through a lumbar puncture as the scan is going on. And just like that, you saw that split earlier in some of those other cases, you see a nice split in the contrast column here associated with this calcified disc, and so now you've very effectively localized where this leak is coming from, and then you just have the trivial task of doing surgery to repair that, which is quite easy in all cases. Thank you, radiology. So CSF to venous fistulas are another challenging area. They can be hard to see, so that's the problem. There's a couple different ways we can look at them. Again, with a dynamic myelogram, where you just have the patient in decubitus position and you run contrast up over the area that you're suspicious about. This is a image of Dr. Shevink's from the literature, where you can see this nice big fistula. I think you probably have seen that case before today. And then you can see it on CT myelography in what's known as the hyperdense paraspinal vein, which is basically contrast filling a paraspinal vein that you can trace backward, usually to a diverticulum of a nerve root sleeve. So these are different options for imaging CSF to venous fistulas. I will say this was given to me by Levi Chazen, who I think he was a fellow at UCSF before, but now is in New York. This is an intrathecal gadolinium MR, and he has accumulated a couple cases where you can nicely see CSF to venous fistulas. In this case, this is the fistula. It's filling some paraspinal veins here. So we have all but given up on intrathecal gadolinium. There may be some new life to it if other people can make it work. Now, for CSF to venous fistulas, I think you have to know what you're looking for. Sometimes they're easy and sometimes they're difficult. This is an example of a CSF to venous fistula seen on a CT myelogram. When, in the beginning, these sort of things were not obvious to me that they were actual fistulas. You see this sort of hazy opacification that looks like it's in the epidural space. Below this nerve root. I might have thought that this was a little CSF leak, but it turns out this is actually in the internal epidural venous plexus, and this is filling that internal epidural venous plexus. And I'll show you the video here, if it'll play, just to show you that it kind of extends inferiorly out of a nerve root, and you can actually see it sort of wrapping around the corner here as it flows into a paraspinal vein. This was confirmed with a dynamic myelogram, and it was taken to surgery, and it was a fistula. Here's another case. This was from a digital subtraction myelogram back before they were done in Decubitus position. This is what, you don't see much on that myelogram, but again here, relatively subtle, but coming off of this nerve root here, there's a little too much stuff, and it kind of goes down here into the internal epidural venous plexus in this sort of tubular form. On the coronal images, again, it's this kind of wispy, sort of ill-defined, little bit of contrast coming out that you can see on several images. Again, this was confirmed to be a CSF to venous fistula. So the subtle appearance of fistulas in the internal epidural venous plexus, one, you have to be familiar with the appearance. Two, you have to get a good contrast bolus. Three, you have to use thin section imaging. So these are sub-millimeter slices, and you have to scan pretty quickly after the contrast goes in order to see them. So thin images, good contrast, quick scanning. Here's an example of a very subtle CSF to venous fistula here alongside of the thecal sac. This was done at an outside institution. Thicker section images, quite delayed. It was like 20 minutes after the contrast injection. The contrast is not really all that bright, and you don't really see the abnormality here. So I think, again, technique is important, and some imaging is not the same thing as good imaging. Here's another example. This was an outside prior myelogram. The contrast actually looks okay, but it was kind of a delayed scan. We repeated the myelogram, exact same level. On the immediate scan, you can see that there's this filling of the internal epidural venous plexus. And again, I'm not showing you the fistula at the end, but this was confirmed to be a CSF to venous fistula. So looking for that, knowing to look for that is important. Sometimes repeat studies, as have been mentioned before, or different modalities, just getting a second look can sometimes be useful. Here was a case, this was a patient who had a dynamic myelogram. There's this diverticulum here. I wasn't 100% sure that these little nodules that I was seeing underneath this, I didn't really know what that was, if that was just a nothing or was that a fistula. So this patient went for an immediate CT myelogram. You can see the patient was in the lateral decubitus position. You'll see this diverticulum, but I want you to look in the epidural space here next to the thecal sac, and you'll see all these little channels of contrast filling in this sort of reticular pattern down here below the nerve root sleeve. Here it is on a coronal image. You can see this is the big diverticulum, and you can see these sort of smaller channels that are filling in what is a CSF to venous fistula. So again, you need very good imaging, you need high contrast concentration to be able to sort of see these things, and most of all, you have to know what it is that you're looking for. As other speakers have mentioned, decubitus imaging is better for CSF to venous fistula detection, so that would be my next tip. Here's a case of a patient who had just this tiny little, very subtle linear thing out here in the nerve root that was on this initial scan. This is a slightly thicker section image called a MIP. Of that same area, just to show you what this looks like, and you may be looking at this and saying, oh yeah, right, that is nothing. I would have just blown right by that. So what we did is we took the patient, in that same session, we just turned them onto their side, turned them into lateral decubitus. And now there's a little bit more there. And maybe you're still saying, that's nothing. Well, this time we took the patient and we did the myelogram, and we injected the contrast without rolling the patient, so just injected it in lateral decubitus and left it there. And now you can see there's a very clear CSF to venous fistula here. So decubitus seems to be very helpful. Here's another example. This was a CT myelogram that I did maybe a month ago. It looked pretty normal at this level to me. I turned the patient into lateral decubitus, and just to help orient you, I'm going to turn this. And what you can see is this little bit of contrast, which was not on the prone imaging. And this is contrast filling the internal epidural venous plexus. This patient had this dynamic myelogram, and it's a little hard to see, but there's all the sort of these linear reticular things filling out from around this nerve root sleeve, and this was a CSF to venous fistula. So just turning the patient decubitus, if you don't see anything on the initial scan, can sometimes be helpful. Another example, here's a patient who had a prone scan, don't really see anything. This is what the decubitus image looked like. Again, the same little bit of contrast. It's just sort of in that gutter that Dr. Dillon was talking about, which is filling in the internal epidural venous plexus. Here's the dynamic myelogram images, and you can see this vein that's coming down off of this nerve root. So decubitus is your friend. So finally, the last thing I would say is that when you're looking for CSF to venous fistulas, one thing that we have found is that phase of respiration is actually really important. So here's a patient, and this was obtained during inspiration, and hopefully you can see that there's this really big venous fistula coming off of this upper thoracic nerve root. We asked the patient to Valsalva and watch this under fluoroscopy, and this is the first image. You can see it's a little less extensive. About 2 seconds later, the patient's continuing to Valsalva. Now you don't see any filling of that fistula. And again, the third image obtained another 2 seconds later, it's completely gone. So it's no longer filling. So what happens is that when you take a deep breath, you get sort of an increased venous return back into your chest, and so you get this differential between abdominal IVC and thoracic IVC that sort of sucks blood back into your chest, and you get increased filling of the right atrium. And as a result, if you have a fistula, it's going to suck CSF through that fistula as you're driving venous blood back into the chest. So then we had the patient release Valsalva and take a deep breath again, and now you can see that fistula again. So a deep breath is often important, particularly in the thoracic venous fistulas here. Just to show you another example of that, this is a patient, you're going to start to see a CSF to venous fistula coming in here, which you can start to see a little bit better as the contrast density gets a little bit more in the area of the fistula. We ask the patient to take a deep breath, and now you can see the bit that was filling before, but there's this whole other pathway of venous drainage and this almost like saccular component beneath it that fills. And then finally, when the patient exhales and we image in end expiration, those little channels start to disappear again. So there is an effect of respiration on the filling of these venous fistulas, and I think taking a deep breath is important. This is that same patient. CT myelogram on the left was an outside one. The patient had a lot of respiratory motion. You could see on the axial images. Couldn't really see anything. And here it is on inspiration. You can see the filling of this really big venous fistula. That's the same patient I showed you in the last scan. So in summary, I think some imaging is not good imaging, and you really need to become comfortable with whatever technique it is that you decide that you want to use, whether it's MR or CT or digital subtraction or unsubtracted, and you need to really pay attention to the technique to try to optimize that. And again, it's a moving target. Next year I hope to be hearing about something or talking about something different than what I heard this time. Thanks very much.